Hello, and welcome to Hadassah on Call, New Frontiers in Medicine. I'm your host, Maayan Hoffman. We are now 4 months into a war that no one in Israel wanted, and life is still not the same as it used to be. More than 200,000 Israelis remain displaced from their homes, and tens of thousands of soldiers are serving in the army and on the front lines, fighting the terrorist organization Hamas. Just before I came to record this podcast, I learned that the son of the owner of our neighborhood grocery was killed in battle the day before. It's all personal for all of us, no matter where we live or who we are. Each month, I will try to share a bit about what it is like for the Hadassah medical team since October 7. The Hadassah Medical Organization is playing a pivotal role in supporting our soldiers. Last month, after 21-year-old Shiloh Segev was shot multiple times in a gunfight with terrorists in Gaza's Jabalia neighborhood, doctors at Hadassah Ein Kerem successfully reconstructed his shattered knee. After undergoing emergency surgery to clean his wounds and temporarily treat the knee, major reconstructive surgery followed. Doctors used a 3D printer to help them determine exactly how to reconstruct the knee. Bone was taken from Shiloh's pelvis to replace his shattered thigh bone. Congratulations to Hadassah. The Hadassah Medical Organization's HMO Cardio-Oncology Center has been named Israel's first center of excellence by the International Cardio-Oncology Society when many international institutions are boycotting the Jewish state. The Cardio-Oncology Center was established about a decade ago and treats more than 250 patients yearly. The ICOS Center of Excellence certification is the only cardio-oncology certification to recognize institutions and practices with superior expertise. For more information about the stories you've just heard about and more, visit the Hadassah Stories website at hadassah.org/stories. That's hadassah.org/stories. Today's show is about our hearts. According to the Centers for Disease Control and Prevention, more than 60 million women in the United States are living with some form of heart disease. It's the leading cause of death for women in the U.S. and is responsible for 1 in 5 deaths. It is also the #1 killer worldwide. We'll talk to Dr. Donna Zfat-Zwas about heart disease in Israel and get advice on staying heart healthy this new year. Welcome, Dr. Zfat-Zwas. So during the intro, I revealed some very striking statistics about heart disease. For example, that 44% of American women are actually living with the disease. Tell me, is this also the case in Israel? And is it the #1 killer here as it is in the United States?
So almost every woman over the course of her life will encounter some element of heart disease. When we talk about heart disease, we're really talking about cardiovascular disease, the heart and how it interacts with all the blood vessels in the body. So if you think about it, hypertension is the most common form of cardiovascular disease that there is. And by the time women get into their 70s, 80s, and beyond, a very, very high percentage of women are dealing with hypertension. In addition to that, over the course of one's life, one may develop arrhythmias, one may have episodes where they lose consciousness or become dizzy, palpitations. There's just a myriad of different aspects of heart disease that women encounter over their lives. Heart disease is a leading killer of women in Israel, but over the past 5 years, cancer has been the leading diagnosis, with heart disease being the second.
For women and for men?
For women and for men.
So what about in terms of the types? You mentioned hypertension being something that almost women will develop by the time they're over a certain age. When we're talking about, over the course of a lifespan, what is the most common form of heart disease? Is it hypertension, or are there others that are in the top 3 to 5?
Hypertension is the most common. I think palpitations and arrhythmias are almost as common as hypertension. As women age, heart failure becomes a very leading diagnosis. And for women in their 80s and 90s, almost 60% of them will have to deal with some element of heart failure. And about a quarter of women will deal with ischemic heart disease, with blockages in the arteries and events related to atherosclerosis and buildup in arteries.
In one of the previous episodes that was actually about hearing, the doctor was explaining how while medicine is, helping us to be able to live longer and is, allowing us to survive, that our bodies don't necessarily know that's going to happen. And therefore, we still lose our hearing as if we weren't going to live longer. Is that the case with the heart as well? Are we seeing heart disease hit women and then they sort of live with it for a decade or more?
So heart disease is something at this point in time that we work on first preventing, and if it does happen, then managing it. And we really do see it as a management challenge, in particular heart failure, for example. With the right medications, a person lives with heart failure, goes on about their lives. They may be somewhat more limited than they were before, but they continue.
Amazing. What are some of those basic actions when you talk about prevention that women could take in order to stay heart healthy?
So the basic elements of prevention are the evaluation of the standard diseases that we consider risk factors for heart disease. So checking blood pressure, managing blood pressure. It turns out that the older you get, the more medicines you need to manage your blood pressure. And it's important not to just take one med and think you're okay, but to actually get to the targets. Cholesterol, measuring cholesterol. And nowadays, there are so many different medications that can be taken to manage cholesterol. Preventing diabetes, but if you have diabetes, then taking the medications in order to control it. But then there are also the lifestyle choices that we make that truly prevent heart disease. We finally have some randomized controlled trials where we've shown that the Mediterranean diet reduces the risk of heart disease, reduces the risk of cancer, and reduces the risk of dementia. In addition, exercise is really the magic bullet, the magic pill. Unfortunately, you can't just swallow it. You actually have to do it. But exercise is a game changer at any stage in life and can really make a huge difference in preventing heart disease and helping people live with it. The other thing I should mention is sleep. And getting the right amount of sleep, not too much and not too little, is also a crucial element in the prevention of heart disease.
When you talk about exercise, is there a magic amount of exercise? What are you recommending?
So the recommendations of the World Health Organization, which have been adopted universally, are 150 minutes per week of moderate exercise. When we say moderate exercise, it depends on who you are. What's moderate for one person is not moderate for someone else. But it's exercise where you can still continue you're sweating and out of breath, but you can still continue to talk in full sentences. Or 75 minutes per week of vigorous exercise, which is exercise that is so intense that you cannot complete a sentence.
Wow. And with the other question is regarding sleep. You mentioned not to get too much, not to get too little. Is that different for every person, or is that something that's pretty standard as well at this stage?
Clearly, we all have the right amount of sleep for us, and we have our own native sleep cycles, but we know definitely that less than 5 hours and more than 10 hours significantly increase the risk of heart disease and other diseases. However, we know that just not enough sleep, whatever your baseline is, adversely affects your ability to function and leads to worsened outcomes.
So I want to jump to something a little bit different now, which was an article recently in the New York Times that spoke specifically about a procedure that takes place, I guess, in the heart community. It's called I'm going to actually read it. It's called CABG. It's pronounced CABG, I guess, CABG. And I mean, what is this method, and what is your experience with this method?
So when a person has blockages in the arteries of their heart, or they have a heart attack, which is an acute blockage of an artery of the heart, there is an area of the heart that's getting insufficient blood flow. And the treatment for that is to open the blockage and help the heart achieve adequate blood flow. If there's only a blockage in one artery, then we'll open it in the cardiac catheterization lab with a balloon and a stent. If, however, someone has multiple blockages in multiple arteries, then we find, depending on circumstances, guidelines, and the individual that we're talking about, that doing a surgical procedure whereby instead of opening with a balloon and a stent, but we actually graft arteries that bypass the blockage. So you will take, for example, an artery in the chest called the left internal thoracic artery or the left internal mammary artery, dislodge it from its position and actually sew it on to a major artery of the heart. And thereby the heart is getting blood flow through an unblocked artery. We can also use arteries from the wrist, what we call the radial artery. And we can also take veins from the leg. We call that a vein graft. And we take these arteries, we sew them from the aorta, bypass the blockage, and sew them onto the healthier part of the artery, and thereby achieve blood flow.
So in that case, you're leaving the artery blocked, but you're just adding kind of a new artery in order to allow for the flow.
Like building a bypass road when there's a blockage.
It's incredible.
So it's done by our cardiothoracic surgeons. It's an operation that's been done for many, many years and is, considered standard at this point.
How many of the patients that are receiving this CABG treatment are women versus men, and is it as successful for both genders?
So approximately 25% of the people who undergo bypass are women. So 3 men for every woman. And that's actually similar to the proportion of women who have heart attacks. Men tend to be more likely to have blockages in their arteries and be more likely to have heart attacks. Therefore, the treatment is in proportion.
Okay, that makes sense. But in terms of success,
we know that the likelihood of complications or even mortality after bypass surgery in women is significantly higher than the likelihood in men. It's interesting, a study just came out looking at the past 10 years and showing really there is still a very significant difference between men and women, and it has not significantly narrowed over that period of time.
Well, why is that? Like, why is the success rate less, and why is it not narrowing with all the advances in medicine?
We still don't really know the answer to that. There are a lot of hypotheses, and we've been trying to look at it. One reason is that because women may be smaller and their arteries are smaller, it is just technically more difficult to do the procedure. The same is true with balloons, but we need about a 3 millimeter artery in order to be able to sew. And sometimes in women, 2 of their arteries are okay, 1 of them isn't. And so we do what's called incomplete revascularization. Rather than bypassing all the blocked arteries, we only bypass 2 out of 3, and then the procedure is just not as good. That's one possibility. Women also tend to have more bleeding in general, and that's also another complication that can lead to anemia and more complications after surgery. They tend to be more frail. They tend to be older, and they tend to have more other diseases such as diabetes and hypertension. So all those things coming together may contribute. Even when we take all those factors and adjust for them, there's still a 30% increase that we can't explain. And we're really working on trying to understand what it is so that we can intervene and reduce the mortality in women. We do find in general, women have less atherosclerotic disease, less heart attacks, less blockages, but when they do get them, they get into more trouble.
Wow. It's actually very interesting. I mean, do you think with the advent of new technologies, you mentioned the sewing in a certain size that the arteries need to be, as we're able to move towards potential assisted, surgeries like this, hopefully in the future, do you think that could solve some of those problems? Is that a vision?
I think the technology is going to be biological and not technical.
Okay.
I think that we're going to hopefully learn how to make the heart grow those new vessels rather than be mechanically bypassing them. And that's where the answers are going to come.
Are there other heart surgeries that are more or less effective for women as well? Or is this really the one? And, if so, what are we doing in those cases?
So one of the most common procedures that we do nowadays is aortic valve replacements in the cardiac catheterization lab. Dr. Elbaz, who's one of our cardiologists, also a female cardiologist, just recently published a study looking at sex differences in outcomes. And we find, again, women after aortic valve replacement, what we call TAVI or TAVR, have a higher complication rate in the month after the surgery. But if they survive that first month, then they do better in the long run. Interestingly, there's another procedure which is called cardiac resynchronization therapy, where we put in a special pacemaker for hearts that are contracting dysynchronously. The 2 sides of the heart are contracting differently. And we find that women do better after that procedure than men. Unfortunately, despite the fact that they do better, cardiologists are less likely to recommend this procedure in them, which is something that we're continuing to work on.
You've mentioned a lot of differences in terms of, women and men as far as the success rates of the surgeries, some of the types of surgeries that they can be doing. And I was doing some research, in preparation for the interview today, and noticed that There are also some unique aspects to treating the heart for women or to addressing staying heart healthy for women versus for men at different stages of women's lives. So, for example, one of the questions I was wondering about was birth control. When women are taking birth control, does that have any effect on their heart health?
So it is important when you take a birth control medication to check how that medication affects your cholesterol levels. There are people in whom certain birth control preparations can lead to very high cholesterol and adversely affect their prognosis because of lipid cholesterol issues. So that is something that's important to do. And we also see during menopause that there may be abrupt changes in cholesterol levels. So menopause is the time to start measuring the cholesterol again and to address it if necessary. Other female issues that it's important to talk about is pregnancy. Pregnancy is a form of early warning stress test. And we see if women develop diabetes during pregnancy or hypertension during pregnancy or preeclampsia, this is a group of women who are at risk in the long term to develop heart disease. This is a group of women that we should really keep a close eye on and work together with them to develop healthy lifestyles and prevention. We're working on developing a program targeting those women here at Hadassah now that we're very excited about. After we did focus groups to find out what these women really want, because just giving them a program isn't going to do it. So that's another avenue. The other thing that's important when we talk about menopause is that the timing of menopause is important. We know that if a woman has, for example, surgical menopause, has her ovaries removed, that she's at increased risk, and it's very worthwhile to take estrogen if that happens. And that in general, early menopause is associated with increased risk down the road.
Are you seeing you've been a cardiologist for a long time, and I'm wondering if in recent decades or the recent decade, you're seeing that these are becoming more problematic than in the past. Number one, because of the increased obesity or being overweight when you go into pregnancy, which tends to be more of an issue today than it would have been maybe in the past. In addition to that, with regards to the hormones in all of our food and the things that are starting to impact people hormonally, is that also impacting then some of these other questions that then leads to needing to be even more careful or cognizant of the heart health?
So obesity is a major issue, both in terms of the development of diabetes and all the bad things that happen as a result of diabetes, the development of heart disease and the development of atherosclerotic heart disease and the development of heart failure. And perhaps the most common problem with obesity is actually heart failure. Um, in It's a major issue. I think we are thankfully now gaining access to new medications and new avenues to intervene that may make big differences. And I hope that from a public health standpoint, we'll be able to make these available. Because if we manage to treat obesity and help people manage the chronic disease, which is obesity, we can make massive differences in outcomes down the road.
Do we not want to address it? I mean, I have a question regarding the medications because I do know that some of the medications I'm assuming you're talking about are some of these shots and other things that are available for people who have acute diabetes and not necessarily people who are just overweight right now, though some more people are starting to be able to take them. Are there any concerns about taking medication for that long? People are overweight from earlier ages. Like, when are we giving these medications, and couldn't that potentially also, though, have a long-term detrimental effect?
So these medications that you're talking about are what we call the glucagon-like peptide agonists, meaning glucagon is a native hormone in your body, the hormone of satiety. So when you eat, your stomach stretches and it gives off this hormone called glucagon, and it goes to your brain and says, okay, I'm full. So we've learned that the problem with glucagon is its half-life in the circulation is a few seconds. So they took glucagon, they changed it chemically somewhat, and they've created a situation where it lasts longer in your body. And it exists as shots, and they're now starting to actually develop oral preparations. The best thing is always to prevent obesity, is to eat right, to exercise, and not get to that point. But in my clinic, and the preventive heart clinic, I see many women who have been struggling with diets and trying to lose weight for 30 or 40 years. And they've tried every diet out there. They've tried everything. And this is not about failure. This is about, on some level, a physiologic changes in the body that no longer enable them to lose weight through standard behaviors. And in this case, I do believe that in certain circumstances, for the right woman, and all treatment has to be individualized, that long-term treatment with these agents may be beneficial. We find that about 70% of people can tolerate these medications and can benefit from them. And there are more and more coming out and oral preparations. And I really do believe that we need to start early. We need to prevent diabetes by changing the foods that people eat, the access to foods, what we consider cool, what kids like. But at the same time, we need to address what's happening with women who have been fighting this for many, many years. I just want to add that recently in August, a study came out where they gave these medications to people who had heart disease and were able to show a significant reduction in heart attacks and mortality in people who are taking these medications. So at this point in time, if you can tolerate the medicine and it's right for you after discussing with your doctor, it does seem not only to be safe, but also to reduce your risk in the long term.
Amazing. So speaking of risks, the war here in Israel is still going on. We talked about it in the introduction, and we're going to, we can't really have a conversation without speaking about the war that's raging in Gaza and in Israel, and, in general, with all of our soldiers who are there. But I'm assuming it also has an impact on general health, just the stress levels and other aspects, I'm assuming. Have you seen an increase in patients since the October 7th?
So, stress affects us in multiple ways. One way it affects us is really through our behaviors. We eat comfort foods. All the people I was trying to talk into quitting smoking are like, not now. People either have the energy or don't have the energy to exercise. Really, it adversely affects many of the preventive behaviors that we want people to do. We also know that stress affects our hormone levels. It affects our adrenaline levels. It affects our steroid levels. And in the long term, these stressful events affect our immune system, increase our risk of developing atherosclerotic disease, and cause immunosuppression. And I think we are more and more starting to see stress-related illnesses. One particular thing that we see more frequently in women is what we call stress cardiomyopathy. And that may occur when someone gets very, very bad news, where they have an episode where part of their heart just stops functioning. It's like a heart attack, except there isn't long-term damage, but it is very high risk at that time.
It's something I think we heard about a hostage, right? Experiencing who came out, an older woman. Yeah.
Exactly. So a hostage came out, was told bad news about her family that she did not know while she was a hostage, and developed, sometimes we call it takotsubo or stress cardiomyopathy or broken heart syndrome. So we have, unfortunately, here at Hadassah and other places in Israel, seen quite a bit of that in the setting of bad news. But this is something we've seen more of than we normally do, but it's still a very rare syndrome. I'm more worried, in all honesty, about the long-term implications of what's happening now, and not what we're going to see right now, but what we're going to see in 2, 3, 10 years because of this. Because I think if people aren't smoking, in 5 years, we're going to see the result of that. If people are eating more or eating the wrong foods, in a couple of years, we're going to see that. I think this is going to be a longer-term blip.
And you feel that it's going to maybe even be more acute because of coming off of COVID. I mean, we had just gone through this period of COVID. People were just starting to sort of come back to life. And here we've had this war.
I think in particular in the older population was very adversely affected by COVID. And, we're still seeing the ramifications. It's interesting. In every one of these challenges, I feel like I've learned a lot more about women and heart disease. During COVID, I learned about 2 major issues. One is the cardiovascular cost of loneliness and isolation, and how significantly that affects cardiac prognosis. I also learned about violence because there was a significant increase in intimate partner violence in COVID, and really we became much more aware of the impact that has on cardiovascular health in women. In this situation now, and we're really still at the beginning of trying to learn our lessons, I think what I learned the most about is the concept of meaning. I think that, what happened in this country right after October 7th was many people sought to volunteer, sought to find meaning, and really this was almost inspirational to see how people use meaning to help themselves cope with stress and cope with what's happening. And I think we're also working on using that as part of our interventions now to help women.
So I'm going to ask you a little bit before about the technology, the precision medicine, some of those new things. And as we wrap up, I just want us to look to the future where hopefully not only the negative implications of what we're going through now, but also the positive of still being in a period of time where there is new technologies being developed all the time. I was meeting just a couple days ago with actually Professor Amnon Shashua talking about his vision of artificial intelligence, and it really blew me away how it will impact every aspect of our lives, including health. Do you see in your own work not only the challenges you'll have to address, but are there new opportunities that are coming down the pike that we should expect as well?
I think there are opportunities all over the place. And one of the wonderful things about living in the startup nation is being surrounded by creative people who want to take their ideas and make them happen. Artificial intelligence is going to make a huge difference in our diagnostic capabilities. Ultimately, I do cardiac imaging as one of the things that I do, but I think a computer is just going to be better at it than I am, and we're all going to benefit from that. It's also going to help us understand who's at risk in ways that we don't understand now. I think that by looking at medical records, we're going to see constellations of findings which are going to tell us this is a person who's going to be at risk in the next 6 months, and we'll be able to intervene. I think that we're also, the more we learn about molecular biology and how the heart works, it helps us develop opportunities for intervening. We're actually working now with a bioengineering person to develop specific heart muscles to try new and creative compounds in order to try to prevent disease down the road. We're really living in amazing times.
Is there anything else you want to add that I didn't ask you, something you feel like you want to share that we didn't get to talk about?
I think it's important for me as the head of the Women's Heart Center to reach out to Hadassah women to advocate for women's health. Despite the fact that we know more, that we're learning more, that our biological knowledge is increasing, we still face gender issues. We still find that women go to the doctor and don't get the care that they need. We need to advocate for very simple things. For example, medications come in standard pill sizes, but these standard pill sizes may be fine for a 170-pound man, but they're not fine for a 120-pound woman. And we really need to get our FDA to work with the drug companies to find out what are the right doses for women, and so that women are being treated appropriately. The same is true with procedures, like you mentioned. And it's just, women are not just smaller men. We need different treatment. We need to do the science to find out how to do it.
Thank you very much.
Okay.